Hi, folks. Good morning.
Welcome, everyone. Courtney, do you want to give it one more minute
Yeah, I was
as
just
people
gonna say,
trickle in?
love for folks to put your name, your organization in the chat, just so we get to know folks that are here this afternoon, this morning. Hi, Henry. Nice to see you today. Hi, Helen. Yeah, Audrey. Welcome.
Okay. Oh, yep, people are coming in. Okay, I see 11:31, so I think we can kick it
Wonderful.
off. What's up?
Is it wonderful?
Okay, great. Welcome, everyone. We're so glad that you're here to be with us this morning for this short webinar. My name is Linda Riddle. I'm with the Office of Main Care Services HIV program team. On behalf of the team, our speaker this morning is Courtney Pladsen. She's the medical director of Main Care. She has served as clinical director at the National Healthcare for the Homeless Council and in the safety net, including healthcare for the homeless clinics for more than 15 years. We feel really lucky to have her working with us, especially during this current HIV outbreak, which began in a homeless encampment. So I will hand it over to you, Courtney. If you'd like to ask questions along the way, feel free to put them in the chat and I will bring them up. Or it's a small enough group. If you want to just unmute, that would be fine too. Thank you.
Thanks so much, Linda. I was looking at the registration ahead of time and it was so helpful because I know we have folks that work in social service agencies, some people that work in healthcare, some people with HIV expertise, and some who don't. So I am going to try to, this is a big topic and we only have 30 minutes. So I'm going to try to give a high level overview, but I really welcome questions. If there's things that you want to focus on or do a deep dive, I encourage that. So please feel free to ask any questions along the way. So we're going to talk a little bit about the intersections of homelessness, substance use, and HIV, talk about harm reduction, trauma-informed care, and then really some challenges and strategies for engaging folks in care. But we wanted to start off with just an overview of where things stand in terms of the HIV landscape in Maine. So typically in an average year prior to 2023 and the decade before that, we'd have about 30 new diagnoses of HIV in Maine. But currently, in the past 2 years, since the outbreak started in Penobscot County, we now have 30 people directly from that outbreak that have been newly diagnosed with HIV. So we've seen a huge increase in incidence in Penobscot County related to this outbreak, but we're also seeing an increase in incidence in other counties as well. So we had the historically low incidence of HIV in Maine, and that's really changing. And I will say that this is not unique to Maine. There have been outbreaks among people experiencing homelessness, specifically unsheltered homelessness and people who inject drugs in Boston, Minneapolis, Knoxville, Tennessee. So there are many other places across the country. The conditions are not unique. And I say that because the conditions that are in Bangor that created the environment for an HIV outbreak are the same conditions in Portland and Sanford and other places across the state. And so it really, for me, underscores the importance of making sure we are really getting this message out about risk of HIV in our state, because people honestly have not been worried about it. And that's wonderful. And now that's really changing, and we want to make sure people have all the information to be able to make the healthiest choices for themselves. So this is just a little bit of what's called the epi curve of showing the number of people that have been diagnosed with HIV pertaining to this outbreak in Penobscot County. So the first person was diagnosed in October of 2023, and we're still steadily diagnosing people. And so this will continue to go on. Of all the people now, this N of 30, just over, I think 60% of people are virally suppressed. That means their HIV is well controlled and the likelihood of transmitting to others is low, but that means that 40% are not virally suppressed and still have the ability to transmit HIV to others. And where the vast majority of people linked to this outbreak, it's connected with IV drug use. And so there's concern that this is continuing to spread. So we need to get people who are have HIV tested and diagnosed, and those without HIV, we need to make sure we're engaging them in harm reduction conversations, getting them onto PrEP, pre-exposure prophylaxis, and really having lots of conversations about this with folks in the community and normalizing these conversations. So this is a concept that I think is probably new to people, but probably just the name. I think it is very rational. So when we think of syndemics, we think of conditions that are defined as synergistically interactive. So when we think of the conditions of homelessness, of IV drug use, of mental illness, and then we think of all of the environmental conditions around that, difficulty accessing syringe service programs, difficulty accessing healthcare, lack of transportation, all of a sudden we create a condition in which if an infectious illness enters that condition, it's really likely to spread. And so we often see HIV doesn't travel alone. It usually has partners of hepatitis C. It brings in other people are equally at risk for other STDs. We see tuberculosis. So really it's the conditions that can lead to this synergistic effect. And we are seeing that now. Sorry, let me go to this next slide. So really overlapping epidemics of substance use, injection drug use, viral hepatitis and HIV, STIs. And then we think of the other conditions of needle sharing when people don't have access to syringes, conditions of homelessness where people are living in congregate settings or living in groups. We have sexual networks or people engaging in survival sex work, and then comorbid conditions. When we look at the data of HIV, STI, and viral hepatitis in Maine, so you see across, these things are all coexisting. The challenge, obviously, is that some of these have treatments and cures and others are lifelong chronic illnesses. So when we're thinking of how we respond in this population to HIV, it can't only be HIV. We really are trying to think of how do we make sure we're getting messaging out around prevention with accessing new needles and making sure we're supporting people understand their risk of all these infectious illnesses. We have done a lot. If folks aren't aware, Maine has one of the worst rates of hepatitis in the entire country. And so of this epidemic, of this outbreak in Penobscot County, there's almost 100% co-infection rate with hepatitis C, and we have seen some hepatitis B. So lots of co-infections happening. And then in this outbreak, we've also seen syphilis. So just say that to mean that it's not only HIV is a risk, though HIV is a lifelong chronic illness. And so we want to do everything we can to identify those that have HIV and those that do not. How do we support them, preventing them from this transmission? So I'm going to move on from this, just background on that outbreak. If folks have questions about those, happy to answer that. And we're going to go forward and talk a little bit around homelessness and health in particular. So the impact of health is bidirectional with homelessness. So a major medical event can lead to homelessness. We see this where people have heart attacks, strokes, they lose their jobs, they lose their housing, and that can precede them entering into homelessness. And then the reverse is true. We see people who are experiencing homelessness have exacerbations of chronic health conditions for all the reasons It's hard to manage your medications. Your meds get lost. It's hard to access healthy foods. You're so stressed. Folks substance use might go up during these periods. Mental struggles with mental depression, anxiety go up. So the numbers are staggering, though. People tend to think just based on stigma and bias around substance use and mental health, but they don't think about diabetes and heart attacks, where you compare housed populations from peers, from same community. If someone is housed versus unhoused, you have double the rates of diabetes if someone's experiencing homelessness, double the rates of hypertension, double the rates of heart attacks. So really much more severe disease burden for these folks. And then when you look into the infectious illnesses, you're 20 times more likely to have HIV, 36% higher rates of hepatitis C. So the numbers are just quite staggering. And then where someone sleeps really does matter. There is nuance in the data that shows if someone is unsheltered compared to sheltered, even if you're experiencing homelessness, being unsheltered, your health, the rate of illness is much higher. So when we look at 3 buckets of physical health conditions, mental health conditions, and substance use conditions, those that are unsheltered have a much higher percentage. And then when you look at trimorbidity, so someone who's experiencing all 3, 50% of people who are unsheltered have experienced trimorbidity compared to a sheltered population of 2%. So this was based on a research study done in California. It's one of the best studies that have been done to date, really comparing outcomes of sheltered versus unsheltered. And so really profound data. And I know the outreach teams can attest to this. I mean, the amount of stress, the lack of sleep, the conditions, the violence for those that are unsheltered is just profound. And so it's not only homeless versus house, it's even within the homeless community, this bifurcation. And just want to say that in our point in time count, just for Maine from 2025, that was done in January, the rate of unsheltered homelessness for people of color was much higher than our people of color represented in the state. So we see also, again, nuance within the data, but we just want to thinking about unsheltered individuals at just much higher risk. So thinking about HIV and homelessness in particular, so folks who are homeless have a much higher rate of HIV acquisition. And then stable housing provides a foundation from which people can participate in HIV prevention and associated with reductions in behaviors associated with getting or transmitting HIV. So we see this with survival sex work. We see this with people being able to access, even if they're still injecting drugs if they're housed, the ability to acquire and store new needles. Just having housing allows someone to decrease their risk of obtaining HIV. So that's just an independent factor in and of itself. And then for those that are homeless and have been diagnosed with HIV, this was a good study done out of San Francisco. They were evaluating their homeless population, and they looked at this on the left is a picture of viral loads. So we want someone's HIV viral load to be suppressed. That means that they are able to live a long, healthy life. It becomes a chronic illness at that point. And so the goal of treatment for HIV is viral suppression. Viral load, the more virus you have, people can become sick and go on to have AIDS. What this showed is that of people that were housed, the average viral load was 7,000. For people who were homeless but sheltered, viral load was 17,000. But for those that were unsheltered, their viral loads on average are 85,000. So homelessness was associated with a much higher rate of not being able to access ART, be able to adhere to antiretroviral treatment, or this is the medication, and achieving viral suppression. So again, just really high barriers, being able to access care and being retained in care and actually achieving viral suppression. So really wanting to think about harm reduction. And so harm reduction is there are specific tools. I've already mentioned syringes, condoms. There's lots of actual specific tools, but what we really need here is a harm reduction philosophical approach to caring for this population. So we know that historically people experiencing homelessness have had very negative and often traumatic experiences in healthcare, accessing care. And so there's a lot of walls up, barriers up. And then especially if they're trying to seek care related to a behavior like injection drug use, they know that whatever they're going to face is probably going to be negative, stigmatizing, biased. And so people wait until they're exceptionally ill to have to get emergent care. And even when they're very sick and show up in the ER, they still often are saying that they get treated terribly. So our charge is, how do we create environments, interactions that aren't adding harm and adding trauma for these patients? How do we actually do the opposite? How do we actually create spaces where people can feel cared for, feel compassion, feel non-judgment, feel like they can show up as their full selves and share and openly talk about behaviors, about their risk? And so we are able to do this in healthcare for many other conditions. We do this regularly with our patients who are diabetics, and we talk about their diet. We don't just say, hey, if you had some carbs or sugar, we're going to cut you off of your insulin. We don't say to our COPD patients, if you're still smoking, then you're not going to get your inhalers. But somehow we have had this whole other paradigm around substance use disorder treatment, where if someone is still struggling with their substance use or taking other substances, there's still threats of taking away treatment. And so how do we create conditions that we are actually reducing harm? We're not adding trauma to patients' experiences and really foster the opposite, where we're actually cultivating trust and we're creating spaces where people can show up as their full selves. And I want to share just in Monday in clinic, I was seeing a gentleman who I've been seeing for 2 years. It's been a long time. I've been supporting him in his substance use recovery journey and through relapse. And, it's been a long time since I've known him. And on Monday, for the first time, he shared with me that he identifies as bisexual. And he asked me about PrEP. But he opened it with saying, I feel a lot of shame about this. I've never mentioned this, but I'm bi. But I've heard about PrEP and I'm worried about HIV. And I said, thank you so much for trusting me. Thank you so much for sharing that with me. I'm so glad that you feel comfortable sharing that. I was like, I'd love to talk about PrEP. That's wonderful. We can reduce your risk of HIV by 99% by getting you on pre-exposure prophylaxis medication. And it just made me think, like, even though I feel like I try really hard to create a compassionate, non-judgmental space, it might take years for someone to actually feel comfortable. So how do we make sure that we're steadily offering that affirming space where people can over time share these things that are really deeply personal? It's really hard for folks to share that they're engaging in survival sex. There's a lot of shame and guilt in that. People have a hard time saying that I'm injecting drugs or I'm using needles again, because 99.9% of their interactions in healthcare have been negative. So how do we actually rewrite that script and create spaces that folks can feel like they can show up as their full selves? So part of harm reduction is building trust. And really, there are the specific tools that we want to encourage. We want to encourage using new needles, accessing SSPs, using condoms, having Narcan, all these other things, not using alone. But we also really want that philosophical approach to all of our patients. So I wanted to think about this, how this can happen in a organization, like really having a person-centered harm reduction approach. So, I work in a health center. And so the way that I think about this is the staff-patient relationship. And this can happen in our social service agencies, in our behavioral health agencies, in our hospitals and clinics. How do we reorient the staff-patient relationship? We're taken away from a patriarchal relationship. You have to show up at this time. If you're 5 minutes late, that's it. You have to do what I tell you to do. That's not building trust, and that's not compassionate. And so how do we really move away from those systems that have been harmful to people, to really have showing up as the provider, as a learner, and as an informer? And what that means is, I'm a board certified addiction specialist. In all of my training, there is not a randomized control trial that my patients neatly fit into. There are no studies, or very limited studies, that look at people who are struggling with polysubstance use, experiencing homelessness. This doesn't get reflected. Our patients' experiences are not reflected in NIH studies. So we have to trust the stories that our patients are telling us. We have to trust their experience in their bodies. They are the experts. And so I am a learner. I learn from my patients all the time. And then I can be an informer. I can say, here's what I know. Here's what the research tells me. Here's what I know about this medication. But it's entering into a really fostering mutuality. And at the end of the day, trusting and supporting the right to self-determination. So how do we set this up in actually a clinic setting? It takes training from the front desk to the prescribing provider. Instituting pragmatic measures of success, like celebrating the small wins, a reduction in use, or accessing new needles rather than using the same needle. Those are wins. Someone is actively making progress to reduce harm or to reduce transmission of infections, that's awesome. I tell my patients all the time, whether by an inch or a mile, progress is progress, and we're going to celebrate it. So how do we get away from being punitive, being negative, looking at things in just black or white terms in terms of all or nothing approach? It's just not helpful. Our patients have so much internalized stigma and shame that we need to just be really affirming and celebrate the fact that they came in for their friggin' appointment. That's huge. That's a win. We're going to celebrate that. And I tell my patients all the time, I'm so happy to see you. You made it. 3 hours late, doesn't matter. You made it. You prioritize this in your day. And so how do we create that kind of flexibility? On the so there's staff-patient relationship that's on interpersonal. Organizationally, really, how do we develop that stigma-free culture through all doors? So everyone we interact with they have a positive experience. How do we create comfortable spaces that are welcoming? How do we care for them when they walk in the door? Low threshold policies. How do we allow people just to come in as themselves, walk in? Flexibility if they're a few minutes late because they took the bus or had to walk here. And then community. This is an interesting one. I thought about this a lot in terms of this person might come in and have a good experience in me or my team, but it's the minute I refer them to a specialist, they're treated terribly. How do we actually create continuums of care where I'm referring someone to the person I know is going to receive them and treat them well? If I am diagnosing someone with HIV and I'm sending them to a specialist that treats them terribly, that they might not actually get to viral suppression because of that negative experience. And so how do we set up continuums or work with our partners to do training to actually, and if that's not a successful partnership, how do we create capacity within our own organization? And that's what we saw in Bangor. We saw that at the hospital infectious disease clinic, it was really hard for folks to access because they're not used to serving this population, like people experiencing homelessness. And PCHC has really done an amazing job at stepping up and growing their own capacity to provide HIV treatment, which they did not do before. So again, how do we create that continuum? And then how do we disseminate harm reduction resources? If your organization is not able to provide syringes, how do you make sure that you're getting that information out to somebody? Are you offering condoms on the counter in your exam rooms? Do we have signage? Like all these other things that just help promote, disseminate information around harm reduction resources. And then trauma-informed care principles. I'm not going to go deeply into these because I think a lot of this is things I've already touched on. But I just want to say voice and choice. Folks always have the right to self-determination. We want people to engage in services that they want to engage with. If they're not ready for treatment, that's okay in whatever way, for their substance use or mental health or HIV. I'm going to be there for them as their primary care provider no matter what. And how do we just say if the person's coming in and engaging with us, that's wonderful. If it's going to take them some time to build trust to actually engage in treatment, that's fine. But part of trauma-informed care is just not adding more trauma. So how do we at least just first provide that space that is compassionate, caring, and then over time offer services when and if that person is ready? But it's not predicated on accessing services. It just isn't. The fact they're showing up and engaging with our team is still a success. And then the last thing I want to share is just some resources. And then I'd love to just answer questions or have any conversation you all would like to have. But there's some great resources on some of our DHHS websites, some clinical guidance. And if folks, this is really high level, but there's lots of deep dives, and we are doing a Project Echo HIV series that Maine Health is hosting, and that's once a month. And they're clinical topics, but non-clinical topics. Sometimes we focus on case management. This week it's hepatitis C. So you're welcome to join us for those. There have been really rich deep learning in that. And so that's been wonderful. But the New England AIDS Education Training Center also has lots of great one-off trainings. So lots more here. And then the other thing I didn't mention that I just want to say for a second is I encourage you all, if your organizations are not doing HIV testing, which not everyone needs to do, but the Maine CDC, because of this outbreak, recommended that we increase the frequency of testing for high-risk individuals. So folks that are engaging in high-risk behaviors that are high risk for HIV, who are people who are injecting drugs, people who are engaging in survival sex work. We want to make sure we're testing folks regularly. And so I just want to encourage you to identify who in your community is doing HIV testing. The Maine CDC does offer some free rapid testing that we can connect you with their team if you're interested in learning more. And then how do we co-locate services? So if you're an outreach organization, is there an ability for a medical partner to go out with you to offer HIV testing? If you're doing food distribution or if you're doing outreach to connect with people, how do we try to co-locate and encourage HIV testing for folks? We know they're in Maine. One of their data points, I can't remember the exact statistic, but we have people who are often diagnosed quite late in their HIV journey. Like people are actually already having AIDS. And so we have many people that are not getting diagnosed for a long time. And that's because we're not doing enough HIV testing. So really want to encourage people to think about how do you integrate HIV testing into the work that you're doing? How do we offer it in a trauma-informed care way? And how do we, if they're positive, how do we connect them to a really wonderful provider? And if they're negative, how do we offer them harm reduction, get them on PrEP, connect them to other resources? Just because someone tests negative doesn't mean that's the end. Well, that can often be the beginning of conversation saying, oh, that's wonderful. Your HIV test is negative, but let's continue to reduce your risk by getting you onto PrEP. It decreases your risk by 99%. So it can be a conversation starter, not ender. So that's it. That's it for my slides. So I'd love to answer any questions folks may have.
I don't see any questions in the chat or the Q&A. Feel free to unmute if you have a question for Courtney.
And I'd love to hear if folks are doing any outreach HIV testing, if folks have any ideas about that, how we can co-locate services, partner to offer HIV testing.
I'll give it a few more seconds here. Oh, I don't have a question, but it doesn't have the option to unmute. Oh, shoot, I'm sorry. Let me do that. Let me see. People.
Oh, interesting.
Oh, camera feature too. Okay, sorry. If you have a question, I can unmute you. So if you put something in chat, I'll see it. Bruce. All right. Okay. I were just 3 minutes here. I will put up in chat the link to the Maine Care Provider Resources page. That has an HIV program section, and in that section we have the presentations and the webinars that were included in this series. So there's HIV prevention, treatment, and resource navigation. All of those are up there. This webinar, PowerPoint and recording will be posted early next week. Is there anything else, Courtney?
And I'll just say, so I've been working closely with the Maine CDC responding to this HIV outbreak, and we've done lots of education. If you feel like your organization, your health center, your program wants more training or education, please feel free to reach out to myself or Linda. We're happy to either offer the training, connect you with folks doing trainings. We're trying to really get the information out that's across statewide. And if we feel like your organization wants a deeper dive into any aspect of this, we're happy to do that. So please don't hesitate to reach out.
Yes, you'll get a follow-up email from this webinar when the presentation and recording are posted, and you can respond to that email with any requests for training support or resources. Okay.
Thanks everyone for
we've got a
attending.
wrap. Yes, thank you everyone.
Have a great day.
Thanks. All right. Boom.